everyone. For those of you that haven't met, I'm Emily Murphy, your Cooper EMS Fellow, also known as MD5. And today we're going to talk about a very common complaint in the pre-hospital setting, syncope. So first off, what is syncope? Syncope is a transient loss of consciousness due to insufficient cerebral blood flow. So what's this mean? Your brain likes the blood because it has glucose and oxygen and other nutrients that it needs. And when it's not getting enough of that for one reason or another, it causes you to lose consciousness. This is followed by a loss of postural tones. This is why these patients kind of flop over and can look kind of floppy and sometimes injure themselves in the process. Syncope, by definition, has a complete resolution of symptoms without any form of intervention. It usually comes on pretty quickly, and it doesn't last too long. It should be less than 5 minutes, and if it's longer than that, you got to think about something else. It's also on a spectrum. Some people will say, I felt like I was going to pass out, or I almost passed out, and near syncope carries a lot of the same risk that actually passing out does carry. So now that we know what syncope is, what causes it? And the answer is lots of things. We're really going to break it down into 3 separate topics. There's reflex-mediated, orthostatic, and then the scary ones that we don't want to miss, cardiac. First type of syncope we're going to talk about is reflex syncope, or neural-mediated or vasovagal. It's one of the more common causes. So our bodies are pretty smart, and they have these receptors that sit within our carotid arteries that sense our blood pressure. If our blood pressure gets too high, these receptors sense it, and they activate systems to try and lower our blood pressure. Vice versa, is too low, they activate systems that try and increase it. So what happens in vasovagal? There's an exaggerated sympathetic response. This is often triggered by getting your blood drawn, the sight of blood, getting some really bad news, being extremely scared of something. And so you get this huge increase in your sympathetic response that's sensed by those smart receptors in our neck. And those receptors in our neck say, no, this blood pressure is way too high, we have to lower it. But they overshoot, it overcorrects. So what happens? You get a drop in your heart rate and you lose the tone within your blood vessels. So you get peripheral vasoconstriction. So that drop in heart rate combined with everything vasodilating causes a drastic decrease in blood pressure. And when the blood pressure is too low, what happens to your brain? It's not getting the blood that it needs, and that results in loss of consciousness. So how's this present? There's usually some sort of triggering stimuli. Like I said, blood draws, fear, anything that causes an extreme sympathetic response. It can also be situational, sometimes with defecation, micturition, or extreme coughing. So these are the people that are sitting on the toilet, straining really hard, and then pass out. So there's usually a prodrome. They're often pale to a bystander, they get lightheaded, they can get a feeling of warmth or cold, they can get sweaty, palpitations, nausea, they can describe blurred vision or getting kind of a tunnel vision, and then they pass out. But the most important thing about this type of syncope is there's usually a prodrome and people often will remember it. Next type of syncope we're going to talk about is orthostatic syncope. This occurs with sudden changes in position, usually lying or sitting to the standing position. So what happens when we stand up? Gravity pushes all the blood down and into our legs, aka away from our head, away from our brain. Our brains don't like that. So like I said before, our bodies are pretty smart, and our body has a way to compensate to ensure the brain gets what it needs. How does it compensate? It increases your heart rate, and it increases your vascular tone so that your brain's getting what it needs. Anything that affects these compensatory mechanisms can cause orthostatic syncope. So a lot of neuropathies, like diabetics, or for another reason, spinal cord injury, Parkinson's, a lot of these patients lose their vascular tone, so they don't have the ability to vasoconstrict in the periphery the way that most people do. A lot of medications can do this as well, especially patients on beta blockers or calcium channel blockers. They both lose that ability for vascular tone and also can lose the ability to increase their heart rate. This can also happen with decreased circulating blood volume. So somebody that's severely dehydrated, if they're bleeding, whether it's been acutely or they've been having a slow GI bleed, or patients that have excessive diuretic use. If you decrease your circulating volume, you can have orthostatic syncope as well. Pre-hospital, it's important to recognize that orthostatic syncope can be associated with a serious underlying medical issue, and they often warrant ALS assessment. So some things that medical problems that can present like this are sepsis, if somebody's severely dehydrated from vomiting or diarrhea, or because their nursing home's not feeding them, if they're in DKA. So really have to get a good history and make sure there's none of these things that are going on with these patients. And if they have any abnormal vital signs like tachycardia, or if they're hypotensive, they should really get an ALS assessment for an EKG and cardiac monitoring. And last but not least is cardiac syncope. This is the type of syncope that is potentially serious and or life-threatening, and something that we do not want to miss in the pre-hospital setting. It can be broken down into both structural and arrhythmia. So structural is when there's a physical impedance of blood flow. The blood cannot get out of the heart and get to the brain, so the brain is not getting the blood it needs, and it doesn't like that, and we pass out. This can often be seen with valvular disease, especially aortic stenosis, cardiomyopathies, tamponade, or PE. Another very common cause of cardiac syncope is any sort of arrhythmia. So what is an arrhythmia? It's an abnormal heartbeat. These can be too fast, such as ventricular tachycardia, scary, bad, SVT, atrial fibrillation with RVR, or atrial flutter. It can also happen if your heart's going too slow, whether it's some sort of AV block, sick sinus syndrome, or they're having sinus pauses. Regardless, what these patients need is a 12-lead EKG in a timely manner, as a 12-lead EKG can help to identify an underlying arrhythmia as the cause of this patient's syncope. So who's at risk? Anybody with a history of cardiovascular disease. So if they've had a heart attack before, if they have any known structural heart disease or valvular disease, congestive heart failure, or if they've been diagnosed with any sort of arrhythmia before. Also, the elderly. If they have any of these things that we've discussed in their history, it should be cardiac syncope until proven otherwise. So these patients really need an ALS assessment for a 12-lead EKG and cardiac monitoring because they're at a high risk of deterioration. So you get dispatched to a patient that says they passed out. What are some red flag signs and symptoms that should alert you that, maybe this is one of those scary cardiac causes of syncope that we talked about? If there's no prodrome, sometimes patients with a arrhythmia or a structural heart disease, they just collapse. So if you get dispatched to a patient that says, I don't know what happened, I just woke up on the ground, you got to think about the cardiac cause and really should have an ALS assessment. If it's exertional, syncope should not happen with exertion. So if somebody says, I was running or I was moving boxes and then I just passed out, that should raise suspicion for a cardiac cause of syncope. I think we already hit home with this one, but if they have any history of cardiovascular disease, it's cardiac until proven otherwise. If it occurs while they're laying down, syncope, like we talked about, the vasovagal orthostatic, that doesn't happen when you're laying down. So syncope that happens when you're in bed should raise concern for a cardiac cause. If they're having any sort of chest pain, shortness of breath, palpitations, those are signs that there's something else going on. If they have a family history of sudden cardiac death, they could have an undiagnosed channelopathy, which basically means an abnormal conduction in the heart. So any patient that says, yeah, my brother just passed out and died when he was 30, that should raise concern for a cardiac cause of syncope. If they're over the age of 40, you got to think about it. And if syncope is prolonged, so if they have loss of consciousness that's greater than 5 minutes, you should raise suspicion that, maybe there's something else going on and this wasn't just your classic syncope. So what are some things that cause a transient loss of consciousness that can mimic syncope? The biggest one is seizures. Some ways to differentiate a seizure from syncope is, one, if they have a history of seizures, any sort of tongue biting, incontinence of either urine or stool, or if they had witnessed seizure activity, these things should point to seizure as a cause of loss of consciousness and not syncope. Some sleep disturbances like narcolepsy and cataplexy. If they have any sort of fall or trauma causing a TBI, that can present like syncope. Also remember that oftentimes these patients that just collapse, they can fall, and so you have to evaluate them as trauma patients as well. If you're intoxicated, some underlying psychiatric conditions, and metabolic disturbances, especially hypoglycemia. All right, so real quick, in summary, so syncope is a transient loss of consciousness. Your brain is not getting enough blood for a variety of reasons. Remember that these patients often fall, so you have to evaluate them for trauma as well. Vasovagal, often there's a precipitating event, there's a prodrome of being lightheaded, sweaty, blurred vision. Orthostatic is your positional, especially in patients that are severely dehydrated. Remember that this can be due to an underlying serious medical problem. And then cardiac, the big, bad, scary one. Arrhythmias, structural. What are our red flags? No prodrome. Patients just collapse. Any syncope with exertion, scary. If they have a history of cardiovascular disease or they have associated concerning symptoms like chest pain, shortness of breath, or palpitations. And as always, if you have any questions, happy to chat via email or to meet in person.